got bones. I got bones. I got 206. I got 206.
You know, it's interesting. I did my swim the other day at the local pool, and I came out and I saw this little pamphlet, and it was called Senior Health Magazine. And I thought, this is interesting. I'm giving a bone health talk tomorrow, which is very relevant to a certain population of patients. Let me just see what it says. And I will say that there was nothing about bone health, by the way. There was nothing about osteoporosis. There was nothing about the epidemic of fragility fractures. But there was a lot about how to mortgage your house, how to live with pets, which is great, and how to sell your house for cash. And I thought, and then there were some other tidbits of information that I thought was useful. And then I thought, so as part of my passion for bone health, it's really education too, because I feel like, is there enough education out there for you as a person, individual patient who may or may not be older than 55 or 65 or 75 of a certain age, gender, ethnic, or ethnicity or socioeconomic background? And that seems like a lot of words all jumbled together, and it's because my passion evolved from a lot of different areas. I trained in Canada, which is the best place in the world, just kidding. And go Habs. And then I came out to California. I was at Stanford on faculty. I researched bone. I studied bone. I taught about bone while I was doing surgery there. And then I went to FDA and I regulated devices that were implanted into bone. And then I went as global medical director at Amgen in bone health, specifically looking at bone health and the various drugs and treatment options for bone health. And now I'm in private practice, putting it all together and assimilating it. Hopefully you'll understand where my brain comes from, because it's an evolving science. I'm still learning, and I'm hoping that I can instill a piece of that knowledge with all of you, because this is truly the most important epidemic that we're having. People talk about the baby boomers and the crisis that's happening right now in financial aspects and social security and all that. But what we're forgetting is that it's ourselves, and I'm including myself, because it's only going to be a couple of decades before I'm going to be concerned about it, and only a little bit longer before, a lot longer, hopefully, before my daughter gets to that age. So what I'd like to do is, unfortunately, so I don't have a clicker, so I'll have to walk back. So. But walking is good, so I'll probably walk a few miles here. And I don't carry a pedometer or anything like that, because I find that when you calculate the number of steps and calories, it just becomes a job. And no one wants to have a second job. We're all busy enough as it is. So the important part that I'd like to share is this slide. And I call this a sentinel event. And that means that this is an event that we have an opportunity to address right now. Because changing bone health starts with actually all of your grandkids. So at the time you're at now, it's too late to try and change what you could have done many, 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 many years ago. Well, maybe I don't want to say that many. Sorry. I apologize. We're all young here. So the important thing is, what can we do about it now? So when a patient comes in with a hip fracture, we call it a sentinel event, because that is an opportunity to intervene and do something about it. Because otherwise, that patient could be sitting around in the community, at a nursing home, at their bingo, bridge, or even mountain biking, skiing, and doing all other activities, climbing, hiking. I have patients across the spectrum, from nursing home all the way to super active 65, 70-year-olds that are active, and as well as others that are non-active. So I see the spectrum. And they may not see their primary care doctor. They may not hear about their bone health or osteoporosis. And they only may be listening to what's read in Senior Living and may be more concerned about why someone wants to mortgage their house as opposed to what they're happening with their bones. So this is a sentinel event where you have a hip fracture. How many people have had a hip fracture already? Oh, okay, 2, 3. Okay. How many people know someone who's had a hip fracture? Okay, several more. Okay. How many people are worried they're going to have a hip fracture? Okay, so I should see every hand up. Just statistics alone tells me, and that's why I want to share with you, that statistics based on national and international data across the globe says that the odds are a high percentage of patients will have a hip fracture if we do nothing. And I'll save that for later as we describe what I mean by doing something and not nothing. So in this particular case, patient had a hip fracture, he broke, and he was fixed. Now, how many people want to get fancy titanium in their hip? Come on, it's all cool. Some of it's blue and gold colored. No? Okay, good. So how many people know what osteoporosis is? Okay, a handful of people. Okay. How many people think they have or know they have osteoporosis? Okay, that's good. How many people think they might have osteoporosis and don't know yet? Okay, how many people think they might have osteoporosis but are in denial? How many people don't care? Okay, good. So no hands went up when, so everyone cares. That's good. So osteoporosis, in a sense, is very similar to when you let termites attack your home. Okay? We all love our home. It's our framework. Without that framework, what'll happen? It'll collapse. So that framework is the most important structure and foundation of everything else. Our arms and joints and muscles and nerves, they're all like lamps and furniture and shades and carpet and paint. That's all they are. The underlying foundation and structure are our bones. Without our bones, we're just like amoebas and protoplasm floating around. Wouldn't that be cool? No. We want to be able to look up and see what's going on in the world, right? So that's the challenge. So termites attacking the bone, and you can see it on the slides. It's pretty obvious. On one side, on your left side, my right side, you'll see that you have normal bone, and on the other side, you'll see that there's osteoporotic bone. You can see the holes, the gaps, the breaks in the trabecula, and you'll see that this is structurally not sound. So if you were to take a cube that's made out of good solid bone versus something that's made out of osteoporotic bone, and you were to stand on it, jump on it, and then crush it like an empty aluminum can. That's what your bones do. Now, how many people believe that, so let's, in terms of the people that have had experience with hip fractures, either themselves or their relatives, how many of you think that the fall caused the fracture?
No, the bone wasn't there. The bone was weak in the first place.
Okay, so it raises a good point, because more often than not, the break happened and then you fell. So a lot of people think, oh, I tripped and then I fell and broke my hip. Oftentimes, and I'll show you an example later, it's simply that the twist or the position or just standing, and eventually it just caved in. Just like eventually something will collapse in a termite-ridden bone or in any situation where the foundation is eroded. Eventually it'll collapse, and at some point that fracture happens and then you fall. And so, but still, falls will still happen. And so the question is, how do we understand our bones? So this is a very complex science. I don't want you to try and digest everything on the slide. Some of you with an engineering background are like, oh yeah, of course. Toughness and strength and all of this is important. But essentially what I'm sharing with you is that bones can be both tough and strong. And does anyone understand the difference between toughness and strength? So that's a good question, a good point, good question, and I will discuss it. The important thing, and I'll talk about it later, the important thing to understand is that bones should be both tough and strong. And so you see on the vertical and horizontal axes, as you go up on both, the toughness increases and the strength increases. And so there are various materials that are tough and other materials that are strong. Some are both. So since we have this, I don't know why there's columns of wood sitting here, but if we were to take this, don't worry, I'm not going to do anything with it. So if we were to take this, right, would people say this is tough or strong? So it's actually both, right? Trees are pretty tough and strong. Like, look at the redwoods, right? I mean, it takes a lot to take a redwood down. Even, well, I mean, it's not nice to talk about fires right now. God bless everyone going through that. But trees are tough and strong. And it's because they have an internal structure that gives them that. So if I were to drop this onto the ground, what would happen? So it probably won't break. If I drop it from 100 feet, it'll probably shatter. But what if I take a piece of chalk and do the same thing? It'll break. So, and I'm going to use that example later. So we know that chalk will drop and break, and we know that wood or plastic, even a pen, will drop and it won't break. So there's differences in toughness and strength. Okay, and that's important to understand overall, and there's various materials that we use. And why this slide is important is because when we go to fix bones, we want to use materials, or when we replace joints, when we fix bones, anytime we're interacting with the human body, we want to try and mimic what's inside the body. And a term you've probably heard a lot recently over the last several years, maybe not, is biomimicry, where we try and mimic what's already in nature. One example of that were the shark-skinned wetsuits and spandex that the swimmers wore in the last several Olympics. There was, based on mimicking the shark scales, they were able to improve their streamline of swimming. So that's a type of mimicry. So we use various materials, ceramics and titanium, and you can see all those various alloys up there. And you see wood is up there too. And so that's important. So what's happening with our bones? Are we getting weaker? So in this slide, we can see that there's young people, and then there's another category of people. I wish they used a different term. How many people think they're aged? Aged. Aged. Elderly. Isn't that a horrible term? Who wants to be aged? But that's what we are. I consider myself aged. Actually, my son the other day says, "Daddy, what's going to happen when you get, like, old?" I said, "Well, I am old." He says, No, but like really old. Like when you can't walk anymore. I'm like, wow, why is he thinking about that at 6 years old? You know, so I mean, I think I hand it to him in terms of some of the learning and schools that he goes to, and you know, exposing him to grandparents and elderly, and seeing, you know, how we interact. But it's kind of like, it gives him a sense of, okay, age is different, time will progress, and height and length and all of that. But in this particular case, if we just look at the data, we see that as we get older, our bones get both less tough and less strong. So that means we are prone to what? Just breaking. Just in general, we're prone to breaking. And the reason I don't say osteoporosis, and I'm going to talk about it later, because there is a unique aspect of osteoporosis, which eventually, in understanding the terminology and lingo, will need to change. So that means our fracture rate increases. So as we get more aged, we break our bones more. And this is for men and women. And male osteoporosis is actually under-recognized. It's absolutely, we know it happens in women. We're predisposed to understand that because women are predisposed to it based on the hormones, based on postmenopause, and a lot of different factors. So women, and I didn't even realize this until I worked at Amgen. If a mother has a baby and is breastfeeding, all the mineral from the bones of the mother are what the baby gets. So the bones of a pregnant lactating female are similar to an osteoporotic 70-year-old woman. And how much time do we give for maternity leave in this country? Nothing. In Canada, you get 9 months, and I think now it's a year. And paternity leave is 3 months, and now it's gone to 6 months. In other countries, it's a lot longer. So I was also part of the Office of Women's Health at the FDA, and so for me, women's health is important as well. And I think it's empowerment to us as individuals, but to women in general to realize, hey, if we understand this data, that will allow us to stand up and fight for your rights to have good quality health care. So, and that's why it's not just, I feel like I don't want to just educate you, I want to educate you so you can share that knowledge beyond. And I think that's important. So in men and women, we know it happens. And in men, it happens later. So what happens when we get older, beyond 70, 75, 85? What else happens? We get more medical problems, heart disease, lung disease. We get slower, and I don't want this to seem depressing because personally, I don't think that should be the case. I think we're understanding aging backwards. I don't think we should be aging the way we are. So what that means is, currently, we get more disease when we get older. So that means if you get osteoporosis or a hip fracture when you're older, your risk of death and problems and complications are higher. So that's the male category. They get hip fractures when they're much older, more like older than 75, older than 85. So they're sicker after they break or at the time of the fracture. So in fact, a woman who breaks her hip might be closer to 65 or 70. A man that breaks his hip may be closer to 75 or 80. So that means the man who breaks his hip is more likely to die. So the mortality in a man that has a hip fracture is higher than in a woman. Now, and that doesn't mean we change how we look at gender, but it just means that we under-recognize the extent of the crisis. And I think that's what's important. And this slide gets to the question of why we're not understanding osteoporosis very well. So does anyone know what osteoporosis definition actually means numerically?
Related to, is the measurement related to what your bones are when you're like 25 or something?
Sure. So it... Oh, yeah. So the response, which is part of the complete answer, and it's a very good answer, is that it relates back to when you were young. And that's true. So osteoporosis is basically a measure when you look at populations and you look at the standard deviation, meaning the variance or how different the population or you as a patient who has a bone mineral density test compares to when it was normal, which is when you were in the 20s. Okay? So your bone mineral density is what defines whether or not you have osteoporosis, but the way we look at it is on this population curve. And how many standard deviations you are relative to the normal. Now this may or may not sound complicated. The important thing is that if your T-score, so that's a relative measure of difference between populations, is less than minus 2.5. So less than minus 2.5 means anything from minus 2.5, minus 2.6, and lower is osteoporosis. And if you're between minus 1 to minus 2.5, you're low bone mineral density. And if you're greater than minus 1, then you're normal. But what does this slide tell you? Where are all the fractures happening? So there's a section of -1. Sorry, it doesn't show up very well on the slide. I'll work on the color scheme a little bit. It might be the way it's displaying. So osteopenia is -1 to -2.5 in the lower part of the curve, and I didn't bring my pointer. And then osteoporosis is that green area far to my left. So that means that, yes, you'll have fractures when you're osteoporotic, for sure. But 80% of the fractures are happening with patients that have normal or low bone mineral density. Why is that? Yes, another question. So the question was, they're more active. Well, that could be part of it, but how did we define osteoporosis? So the World Health Organization many decades ago decided that the cutoff for osteoporosis was -2.5. Well, that was just a random generated number. It's valuable, it's important to understand that, it raises our awareness, but if most of the fractures are happening in the patients that are not that don't have a diagnosis of osteoporosis, we're missing the boat. So we need to understand it based on fragility of bones, not just a numerical definition of -2.5. And the reason I stress this is the number of times I have patients come in and they say, oh, my bone mineral density is fine. Yes, I had a wrist fracture, but I don't have osteoporosis. My bones are fine. And it's hard to share that important knowledge that you have frail bones. Because the definition of fragility fracture is if you fall from standing height or less. So that means if you fall, trip, land, twist, standing height or less is a fragility fracture, low energy. So it doesn't matter what your number is. So I know that one of the areas, and I thought about how do I teach patients this, how do I share it? We should have something, a whole campaign calling Know Your Score, Know Your Bone Score. What's your bone score? Because everyone knows, what other scores are there?
Blood pressure.
Yeah, they know their blood pressure measurement. They know their cholesterol level. They know their calcium score. By the way, how many people think calcium score is somehow related to bones? So we have one hand up. How many people know what a calcium score is? So only a couple. Yes, sure.
My blood had high calcium in it. Is that bad? It's
So-
phasing out of the bone or something like that.
Right. So it may or may not. It really depends. So the question was, if blood calcium is high, what does that mean? That could mean a lot of different things, but if it's within the normal parameters, probably not. Sometimes if you're taking calcium, it can be high. Sometimes you could have other metabolic disorders, it could be high. What I would say is definitely talk with your primary care doctor about why that is, because there's a lot of different causes. But the important thing is that a calcium score is related to heart disease. It's more based on the CT scan imaging of your calcifications of the vessels. So that calcium score is actually related not to your bones. And so I think it's important to realize that for bone mineral density, we need to appreciate that it's not just about the number. It's not just about being having a definition of osteoporosis. Because when I see a patient that has a hip fracture and they basically tell me, yeah, I just tripped and stumbled and fell and I broke my hip, I say, you know what? You have a fragile fracture. My definition, my clinical diagnosis for you is osteoporosis, even if their bone mineral density is off. So we need to change that. Why do we need to change that? Sorry, there was a question here.
Finish that sentence.
Oh, okay. So why do we need to change that? Does anyone know how we are approved for medications? If your doctor wants a medication, how do you know you're going to get it? Is it up to the doctor?
Is Medicare covered?
Right, it's up to the answer was, will Medicare cover? It's up to the insurance company. So a licensed practicing physician recommends a medication for you, and an insurance company who has no license to practice medicine, so they're practicing medicine without a license, using an algorithm, makes a decision on your health. Why do we allow that? Because of the McCarran-Ferguson Act. And why do we allow that? Because the senators relative happened to be part of the insurance company at the time the law was passed. And why do we allow that? Because we allow our senators and congressmen to allow conflicts of interest when they're in office. Sorry. Did I go off on a political tangent? I apologize. But insurance companies are making decisions on your health. You're basically taking away the rights of you as a patient. As a patient and your relationship with your physician. And the physician is the only one who has a license to practice medicine unrestricted. And the insurance companies are deciding your fate. Sorry, the question.
I just heard about your kidneys, too.
Sure. Yeah, so the point was about calcium, and it's a good point, and that's why I think the most important point, and I'll make it at the end of my talk, is you have to meet with your primary care doctor, because every patient is different. So some patients need 1,500 milligrams of calcium a day. Other people need 3,000, 4,000 milligrams of calcium per day if they have hypothyroidism and have a low calcium. Everyone is different, and guess what the clincher is? Calcium and vitamin D, which I'm sure you've heard of, is not treatment for osteoporosis. So if you think you're on calcium and vitamin D, you're not doing enough for your bones. And I'll get to that. I know you guys have all these questions. So this is the important thing about, so let me give you the example that I was going to give here. So chalk, going back to the chalk example. How many people think chalk is pretty dense? Yeah, chalk is dense, right? You can't look through it. If you put you can't even X-ray through it. You'll show up as a piece of chalk. So it's really dense, right? So that means it has a high bone mineral density. How many people can X-ray through this? A decent amount. You can X-ray through wood. So which is denser? This piece of wood or the same size piece of chalk? The chalk. Which do you think is going to break when you drop it? Right. So is bone mineral density by itself enough to understand bone health? No. That's why that slide is truly meaningless. And it's the science that we're trying to change. So as much as it's important for you to get your bone mineral density, get your trabecular bone score, get all the important information that is important for you, you have to realize this is only one tiny sliver of a piece of a puzzle. And the science of this is really important. You know, and I hear someone just exacerbated and frustrated. And you should be. That's what I want to evoke out of you, because no one else will do it. The senator's not going to do it. They've got private health care the minute they take office. They're leaving you with Medicare and all our soldiers and veterans with VA health care. Meanwhile, they're on the front line and you are all on the front line of health, and yet they get quality care and you get Medicare. And that's not fair. That wasn't a political tangent, was it? Nah, I don't think so. So here's an example. How many people know someone or have had an ankle fracture? Okay, a couple. So guess how this lady broke her ankle? You'll never guess. She was sitting on a couch on Thanksgiving Day. She stood up, cracked, and fell down. She didn't fall. She broke and then fell. So, and the important thing is that, and this is why, and I'll get to later, and I think the later talks are on exercise and nutrition, so I won't really get into that too much. I'll try not to, because I'm probably going to be cut off because I talk too much. Yeah, can you tell? So the important thing is that muscles wrap around the bone. So activating muscles stimulates bone. And the muscles don't act on the bones in one dimension, okay? Or 2 dimensions. It's 3-dimensional. In fact, 4-dimensional if you take into account time. So meaning that when you're doing your exercises, what does everyone see people doing in the gym? Is that valuable? No. So, sorry, what was the question?
What do you think? Is it valuable?
Is it valuable? Because what we're doing is we're just doing 1 dimensions. But what do we do in life? Oh, I got to turn the coffee off. Oh, let me catch that ball. Oh, don't drop the grandkids. Is that one-dimensional? No, it's four-dimensional. So we're moving in 4 dimensions, and yet we're exercising in uniplanar, two-dimensional concepts. And it seems like a very simple understanding, but it's not. What do all the, I do the circuit at the local gym. It's just, yeah. Well, that's not enough. So we need more. We need more. And that's why you see plenty and I have learned this from the patients from Asia and from the Asian patients and culture. What do you see at 6 a.m. or 7 a.m. at any park you go to in the Bay Area? Tai Chi. What are they doing? They're doing 3 dimensions. Now add some weight to that. Increase your motion, you don't have to increase your speed, but there's a lot you can do because muscle building also builds bone. But you have to take it easy, one step at a time, and you got to start young and you'll see it in your handouts. I didn't put the slide in just because I talk too much and I have too many slides, is that you'll see when you hit peak bone mass, it starts dropping like a fly. So you have to start when you're young, and that's what's important. So this lady, both ankles broke. She got up, broke both her ankles. One we casted and one we fixed. One was so bad we had to fix. The other one, I said, well, you know what, we can cast it. And so she eventually healed and went on to do fine and was walking again. But that was just an unbelievable experience. So testing your bones is important. We talked about bone mineral density. You get a FRAC score. All of this information, I think, some of it's in your handout, but I think I just want you to know, and even if you don't feel like you know everything or can understand everything that I've said, if I leave you wanting to know more, that is my goal. Then I've achieved what I wanted, because then that means you will go ask for help. You will go to the booth by American Bone Health or Radius or your primary care doctor, who's probably your most important savior. Go to your primary care doctor and say, hey, I need to understand this. I need 30 minutes or an hour of your time, which is hard in this healthcare market. Why? Because of insurance companies. Those insurance companies, right? What are they doing? And then one area, I have no financial connection to Virtuos, but it's an engineer from Berkeley that does incredible work. And he's actually trying to measure bone strength based on the CT scan data from your bone material. So I just want to let you know that science is changing. Eventually this will be available. And so all of that is happening, and we understand this. But the only way it'll happen is when you guys stand up and fight for your rights, for your bones. That's the most important thing. Because what else happens? How many people know what occult means? It's not a cult. It's kind of a silent, something that happens in the background, kind of shady, right? So occult spine fractures. The most recent data shows that over 90% of women have an occult spine fractures. That means they have broken a vertebrae in their spine and don't even know it. They may have coughed or sneezed and something happened and they broke their spine. That, in and of itself, should just raise alarm bells and say, hey, we need to do something. So how many people think it's normal to go from right to left? We see it all the time. Well, my right, your left, right, you know. Okay, if I go like this. So we're progressing, are we? Is this normal for aging? I don't even like that term. No, this is not who you want to be. But this is happening. People assume, oh, you just get a curvature of your spine when you get old, and you use a cane, and oh, the crooked lady walks in the shoe. I don't know. Is that the nursery rhyme? I don't know. So, but no. It's because we're getting occult spine fractures. Now, all things being equal, there are some congenital, there are some spinal deformities, there are things that can lead to that. But in general, a kyphosis happens often because you're getting vertebral crush compression spine. So if you have noticed that you have lost height of even a centimeter, 2.5 centimeters is the threshold, 2 centimeters or more, you should definitely see someone about it and get a special scan. And that's important. So it's important to realize that this is not normal. This is not normal aging. And what we've done is one of the really key scientists is trying to promote this, and I bring it forth to share, is a vertebral fracture assessment. Now, I've convinced a couple of the bone health imaging centers that they need to do a VFA when they do a BMD. And I would say that often enough I see patients that have a vertebral fracture on the VFA when we do their BMD that you need to get this. And so BMD is bone mineral density. Yeah, and VFA is vertebral fracture assessment. It's just looking at your spine. So that's important. And why is that important? Because there's a lot of fragility fractures happening. And I realize I'm running up on time, so I won't spend too much time on this, but it's important to realize that in the grand scheme of things, what causes the most disease and death and morbidity in this country and in the world? Is it cancer? Is it heart disease? No, it's fragility fractures. You take all hip fractures, all wrist fractures, all fragility fractures together, they lump up to a higher number than the entire number of breast cancer. Now, breast cancer is important. I don't want to take away from why breast cancer is important or why heart attack and stroke are important. But we're missing something that is critical to our health. And it's important. Why is that? Because the patient with the hip fracture, they don't die the next day after a heart attack. They'll die a year later or 6 months later. So somehow or the other, people attribute, he passed away, his heart gave out. Well, no. If he hadn't had the hip fracture, he wouldn't have been invalid, and he wouldn't have ended up in a nursing home, he wouldn't have had pneumonia, he wouldn't have had the stroke and the heart attack and the blood clot and everything that goes along with it. I hope I'm scaring you people, because that's the goal. It's not Halloween, it's real life. And it is an epidemic. And the important thing about it is it's rising. So I can tell you right now that, we have 54 million people that are of a certain risk factor. That means 17% of the population. And it's increasing. And it's going to continue to increase. And that's important because if you're losing your health care, and you're only able to get so much physical therapy per year, and you're only able to get so much home care and coverage to help you recover from your hip fracture, and you only have so much maternity leave so you can recover from giving a baby and bringing new life into this world, what's going to happen? It's going to get worse. So it's a very multifaceted. It's not just, I'm going to take care of my osteoporosis and take care of myself. We need to think about it as a society level, from you to your children to your grandchildren and generations beyond. It's very important.
Why is it going up? Let's call it between 17% and 27%.
Yeah, absolutely. So why is it going up is because, people could say, and statisticians and data say that, we're living longer, we're not getting our treatment. And here's another thing. Because I was talking about insurance so much and getting on this political tangent. But since you asked, I'll talk about it. The reimbursement for getting a DEXA scan has dropped so much that it's not cost effective for your doctor to get a DEXA scan for you. Before, 80% of primary care docs used to have a DEXA scan in their office. All of a sudden, and I can go to that slide. I'll go to that slide later. Is that all of a sudden, it was unaffordable. It cost more to get a DEXA scan than the insurance company and Medicare was reimbursing it for. So it's basically kind of like medicine, unfortunately, in this country, in many countries, not all countries, is a business. And you work hard, you train hard, you got to pay your student loans, you have to make money, but then if the reimbursement is not there, then how do you justify it? So that's why now the imaging centers are a little bit separated. They're harder to get, but that's okay. They exist. Find them. Get your DEXA scan. Get it done. Politics, insurance change, reformation, all of that will take much longer. But a high population, like 65% of you are at risk, essentially. This is the Cass Mountain. This is how many fractures happen per day. 2 million per year. And I'm going to save the questions for the end because I'm already way over time. Yeah. And so, and this is a good cycle of one fracture leads to another fracture. So what's the likelihood that if you have a hip fracture, you're going to have another fracture? 50% likelihood. And the odds are 25% likelihood and 50% chance it's a wrist fracture. You have a hip fracture, you're probably going to get a wrist fracture within a year. And 20% of you are probably not going to survive after a hip fracture. Isn't that horrible? Like, what disease that can tell you guaranteed statistically that you're going to die, 20 to 25% of you are going to die within a year? Wouldn't that just raise alarm flags and say, hey, what's going on? And that's what we need to do. It's so important. I'm going to skip a little bit of this. This is some of the financial impacts and some of the marketing that's done to try and share with you knowledge. A lot of that is in your handout. But here's an example of treatment for osteoporosis dropping after Medicare reimbursement changed. So in the middle, right around 2002, you can see everyone was getting treated. Then all of a sudden, the treatment dropped. And it happens to tie in well with when reimbursement on DEXA scans were dropped. And when the burden of documentation for primary care physicians went up. So that meant primary care doctors were so worried about documenting everything because of mandates that they didn't have time for you as a patient to take care of something that's important. Now, it's important to get your heart checked, important to get your lung checked, but we still need to get our bones checked, and that's important. And what's happening in the United Kingdom? Treatment's going up. And when I say treatment, that's treatment for osteoporosis, not calcium and vitamin D. So something's different in what we're doing in this country compared to other countries. And that may or may not be related to healthcare and political tangents, which I definitely will not be getting into. So we are having not heart attacks, not strokes, we're having bone attacks. When you get that fracture, now if you get a heart attack, you will be put on a beta blocker or some heart disease protective medication. What happens when you're getting a bone fracture? Hardly anything. 20 to 30%, if you're lucky, will get treated for osteoporosis or a fragility fracture. And if your bone mineral density is normal, you won't get treated. So that's the important thing to understand. So, and then from a hospital center standpoint, changes are happening. Everyone is looking at, we want to improve the quality of care, we want to do this, and it's become like a political change. There's these things called HEDIS measures, quality measures, all these things. Well, the hospitals and even the insurance companies eventually, but the hospitals need to be responsible for this, and the physicians. So the onus is being put on the physicians now and the hospitals to take care of your health, which is fine, but we need to do that, and we can't do that unless you as a patient demand it, because these quality measures need to happen. 80% care gap. If anyone has worked in business before or knows anything, if you see an 80% gap, you see that as what? An opportunity. This is the biggest opportunity in this decade, or next 3 decades to come, because none of the data looks like it's going to change through 2030, but it needs to. So here's another patient, 25 years old, had a fracture, she just stumbled on some grass, and she couldn't figure it out. And the interesting thing is, initially I treat, okay, you're young, you're healthy, we'll take care of the injury, treat it. But then she took so long to heal that after 2 months I said, something's wrong. I had her get her blood work done, do a full bone evaluation. Turns out she had hypothyroidism. So she had this fragile fracture, dislocation, because she had low bone mass in a 25-year-old. So it's not just the aged, it's the less aged and the young. We're young at heart, right? That's the important thing. So don't let any of that change. So the opportunity care, this is primarily for hospitals. It's a summary slide sort of showing that the opportunity for that sentinel event to be captured by a hospital, an emergency department, people are looking at. Fragility fracture liaison services where you have a fracture, it's like, we rush to you, tell you, we're going to take care of you and make sure you get treated afterward. The problem in a disparate healthcare system is once you leave the hospital, no one can track you. So hopefully these liaison services will help do that coordination. But unless you as a patient demand it, it may not happen. So it's important. Outcomes, obviously, we want to get 100%, but I think we can get there. There's already data saying that we can save billions of dollars in healthcare dollars just by doing this. This has been shown in the Kaiser system, Geisinger network, and other closed healthcare systems that you will actually save money. And I'll skip through the economic impact because we know that's true. So what are the challenges? Medical costs are going up. We're getting older, not aged. But we're young at heart, and so we need to be aware of this epidemic. So that's the most important thing I want to share. So, how many people like to gamble? Slot machines? Yeah, okay, it's fun, right? I don't gamble for whatever reason. So, here's a slot machine, and these are your choices. Who's going to pull that handle? How many people here in the audience want to pull that lever to get one of these 3 prizes? What do you mean? Look! You get hips in your screws. This was a young male who had multiple fractures, and he actually broke his hip playing hockey at the age of 72, and that's a fragility fracture because he had 4 other fractures before that, untreated. Didn't even know he had osteoporosis. Other patient, young lady in her 50s, had a fragility fracture. And this patient recently, 99 years old with a fracture, and her bone was too soft, too fragile to fix. She may not have survived the operation. So we couldn't operate on her. So you're going to pull that lever. What are you going to get? One of those. So what's the best solution? Don't gamble with your health. Why would you gamble with your bone health? And that's important. So treatment options, there's going to be, I think your primary care doctor is definitely or your endocrinologist or rheumatologist is the #1 person you need to go to. Treatment for osteoporosis, there's a lot of drugs out there. I'm not a big fan of the Fosamaxes and bisphosphonates, and if you get a number of people here from academics around the world, they'll argue with bisphosphonates. As a surgeon who looks at bones and puts screws in bones and treats fractures, I would not trust bisphosphonates in your system. So the only options you have right now that are commercially available are Prolia, Tymlos, and Forteo. That's it, as far as I'm concerned. Now, I don't have any connection with any of these companies. Yes, I worked for Amgen before, but I don't have any financial connection currently to Amgen. But the data on Prolia is outstanding. Tymlos, newest drug out there, happens to be by Radius Health. I did not know Radius Health was sponsoring this event, but that is a great drug. And Forteo is a great drug. And that's been out for a while, but you can only take it for 2 years. Everything else, calcium and vitamin D are important. Nutrition, health, balance, posture, everything, exercise is important, but that's not enough. And maybe you have a hypothyroidism, maybe you have some other disease. You won't know it unless you check. So and I just want to thanks to American Bone Health. It's important to do your exercise. There's going to be more talks on that. So I just want to share one last thing. And I want everyone to say this at the same time. What do we want to do when we leave here? Get tough on your bones. In order to get tough bones. So talk to your primary care doc, and don't take your bone health for granted, and don't gamble. And I just want to share this one last slide. My 2-year-old and my son, and you know, I don't want them to suffer any fragile bones. So thank you. Actually, it's not working anymore.
Calcium from algae.
Yes, so the question was, what kind of calcium is important? Is it the big box store calcium that is from limestone, or is it calcium from algae? I don't think there's a good answer to that. I'm always a proponent of natural. So what I do know from a Norwegian or Swedish study, that if you take 1.5 servings of yogurt per day, it'll actually improve your bone health. So I see a lot of people with yogurt on the table. Take 2. But you don't have to call me in the morning. But that's important. So whether it's from limestone, whether it's from whatever, I think that answer isn't necessarily out. I think, maybe we're going to be having a talk by the nutritionist. So I think they may be able to address that. But as far as calcium in your blood is concerned, overall, it's not just one aspect that's important. You could have a malabsorption. You could have an ulcer. You could have some type of infection or disease within your bowels that limits the absorption of calcium. So there's a lot of factors involved. I think all of those need to be taken into account. Yes?
How does parathyroid affect calcium in the blood?
Yeah, so the parathyroid releases a hormone, and what that does is it activates and the calcium in your system. And it's without going into the complex details, if you have hyperparathyroidism, it'll actually leach out it can actually leach out calcium, and it can actually affect how your calcium is metabolized. So it's important that any of these hormonal disorders or deficiencies, all of that, and I'll tell you that I bet you 10 to 15% of patients that have a fragility fracture, turns out they had a little lump or a parathyroid adenoma, or had some hormonal deficiency that said, oh, well, that's why you have weak bones, and no one ever knew. So until you ask about it or look for it, you're not going to know. Question in the back.
I saw on a health special videos that when people got tested that took calcium, there was too much, I think, something to do with their heart or their balance or something. Do you know what I'm talking about?
So the question was that there was a special on CBS talking about calcium in the blood that could affect your heart. So again, that's why it's important. Yeah, so I didn't actually see that documentary by CBS, but I will say that, again, I'm an orthopedic surgeon. I'm not an endocrinologist or a primary care doctor. So the medical side of things are something that, I don't treat currently. But the important thing about calcium in your blood is that it's in balance. You have a ton of calcium in your bones. You have a ton of calcium in your muscles. So when you hurt your muscles, calcium leaches out. So if you're not walking at all and you're bedridden, the body, from an evolutionary standpoint, basically says, oh, you don't need any calcium. You're not moving. So let your muscles atrophy, take out all the bones, all the calcium out of your bones, because you don't need it. You're not moving. So if you don't move, you actually lose it. It's literally losing what you need in your system. So, and there's a lot of different discussions, and sometimes the media can overplay something, but it's important to realize that if you have a deficiency in calcium, you should supplement it. But you have to take into account all the other things, like brought up kidney disease, heart disease. All of those are important. And if maybe you have severe atherosclerosis and you have an elevated calcium for something else, you may actually be contraindicated to take calcium because you have enough in your system. But then there are drugs to help mobilize it and bring it into your system in a better manner. And exercise may be the better way, because how do muscles contract? It's release of calcium within the muscle fibers, within that sarcoplasmic reticulum, which all of you probably learned, may or may not have learned in biology or science, and that causes activation of the muscle structure, the ATP, that results in contraction. So if you don't have calcium, your muscles won't move. If you have too much calcium, they'll shake. So it's a balance. It's a homeostatic evolutionary balance. So if you don't move, you lose it. And if you have too much, you could cause problems. So it's all about balance. Yes?
Would you recap for me? We should be having a bone density test and a fragility.
So just most important thing is make an appointment with your primary care doctor and say, I am scared about my bones. I need to speak to you. But as part of that, get a bone mineral density and a VFA, vertebral fracture assessment. Even though it's not perfect, it's important to at least have something to test, because VFA, vertebral fracture assessment. And the reason that's important is because certain drugs you cannot take unless you've failed a bisphosphonate or your score is greater than minus 2.5. Why? Because the insurance companies decided that was the rule, because they're going to save money, even if you need it. So so that means that an insurance company may force you to take Fosamax, and you have to show that you failed taking Fosamax before you can qualify for something like Prolia or Fortea or something else. Or you have to be at very high risk for fracture before you can get one of the good drugs, because otherwise you're going to get a bisphosphonate. Bisphosphonates are basically these calcium phosphates that go into your bones and crystallize the bone, and they're stuck in your system for months. And they do terrible things to bones. And I'm sure the professor at UCSF who has some good papers on bisphosphonates will stand up and say, if he were here, that, well, that's not true, they're okay, and the data shows this and that. I disagree with it. Looking at all the data, looking at how good the bone is with certain drugs and how less optimal the bone is with other drugs. Bisphosphonates will take your bones to this point, make you more brittle, and then they'll plateau. Other drugs like Prolia for 11 years go straight up like that in terms of your bone strength. Completely different type of drugs. And if you take more than 5 years of bisphosphonates, you're going to run into problems with other issues. Okay? Necrosis of the jaw and atypical fractures can happen. Even though they're rare, they're more common in bisphosphonates. So why would we take bisphosphonates? I don't understand. Do we have time for one more? Okay, one more question.
So if you've been on the bisphosphonates for 5 years, and now I was told Prolia, Prolia, you can switch.
You can switch. Yeah. So the question. Yep.
Is Prolia? You can stay on it forever, and is it a good one to go on?
Yeah. So the question was that the lady here was on Fosamax for a period of time, or a bisphosphonate for 5 years, and was told to take Prolia. Is it okay, and what are the long-term effects on it? And there are great studies showing switching from a bisphosphonate to Prolia actually improves your bone mineral density and strength, and the data goes all the way out to actually 11 years now.
There isn't you're on it for like 2
Prolia, that's the beauty of it. So far, all the safety data, as far as I've seen from presented just in the fall at ASBMR, the data keeps getting better, even out to 11 years. So the insurance will pay for it if you fail a bisphosphonate. Most commercial insurances may pay for it right away, because unfortunately it's not indicated for prevention of osteoporosis. It's been labeled or approved in the market for treatment of osteoporosis. So if you have osteoporosis, you could take it, but most insurance companies will say you have to fail a bisphosphonate. So the easiest way to fail a bisphosphonate is that if you can't handle taking a pill and staying upright for 1 hour and drinking 8 ounces of water, then you fail. That's easy to fail. If someone, and most of my patients can't take it, they can't tolerate it. So I'm not saying that you should do that, but if you happen to take a pill and drink water and you can't tolerate standing upright for 60 minutes or have problems with digestion, you've failed a bisphosphonate. Now, there are some bisphosphonates that are injectables for once a year or every 6 months. I hate bisphosphonates. The data, I am not a fan, but it exists. I almost felt like I sounded like Trump there. Wow, that was scary.
Same way it's injected, right?
Prolia is injected every 6 months, yes. So I think we are out of time for questions. So thank you so much.
Thank you so much, Dr.